Okay, it's 3:03, so I will slowly start with the introduction. And first, thank you very much, everyone, for attending this first webinar of this new academic year. This webinar is organized by the IBIA Special Interest Group on Disorder of Consciousness, so together with Caroline Schnackers and Dr. Nathan Slassler. So for today's seminar, it's a great pleasure for me to introduce Dr. Yitka Annen. So she has been a great colleague for more than 10 years now. So Dr. Annen is a postdoctoral researcher at the Coma Science Group and GIGA Consciousness at the University of Liège, as well as a FWO postdoctoral fellow at the University of Ghent in the Department of Data Analysis under the supervision of Professor Marinazzo. So her earlier training includes a master in biomedical sciences and neurobiology and a bachelor in psychology from the University of Amsterdam. So Yitka earned her PhD in 2019 in biomedical sciences and pharmaceutics, specializing in multimodal assessment, neuroimaging assessments of patients with disorder of consciousness. So her current research integrates neuroimaging and neurophysiological methods across multiple spatial and temporal scales to probe how brain structure and dynamic underpin conscious state. She has applied this framework to topics including disorder of consciousness, but also sleep, anesthesia, as well as extreme physiological states such as apnea or cosmonauts in zero gravity. Dr. Annen has co-supervised multiple doctoral researchers and leads projects in computational modeling of brain states and multimodal analysis of patients with acquired brain injuries. And today, she will give a new perspective on the assessment of patients with disorder of consciousness with a presentation you can see here entitled A Perspective to Assessing Subjective Experience in Patients with Disorder of Consciousness. Quick note, we will take questions in the end, so please keep your question for the end of the presentation, but you can also write them in the chat and we will read them after the end of the presentation. So you can use the chat. You have the small icon in the bottom of your screen or the chat on the right of your screen. So also all people who register to this webinar will receive a link to the recording after this session's end. So now I'm done. So Yitka, now the floor is yours.
Thank you so much, Aurore, for the nice introduction, and also thanks to all the organizers for the invitation. I'm very happy to talk today about this new perspective to assessing the subjective experience of these patients with the disorder of consciousness. And of course, there will be some science in this presentation, but I think it's mostly really a presentation about self-criticism and my wishes for the future of assessing these patients. And now for the offline viewers, perhaps, if you have any ideas or thoughts or questions after watching the webinar, then don't hesitate to contact me by email, because I would be very happy to receive your feedback, comments, or any interaction. So with that having said, I would like to start the presentation actually with a personal story and also actually a long history. But this is my daughter, Fien. She was 5 years at the time when she asked me, "Mom, you are a brain researcher, right? But what exactly do you study?" And of course, it was difficult to come up with a good answer that covers all the things that I study, or consciousness, actually. So I just replied to her, "Well, I study how the brain makes you think and feel." And then Fien took a pause and she said, okay, but sometimes my body just knows how I feel. And I thought it was a kind of a nice comment of her to bring this to light, but we left the conversation at that and went on with the day, as you do with young kids, I guess, might be familiar. But it did linger with me for a bit. And actually, if we go really back in time, like to 3000 BC, the Egyptians did consider the heart as the seat of consciousness. And it was the heart that was weighted after death, to understand if someone had lived a good life or a bad life. And the brain was just discarded before mummification because it was considered a useless organ that should not be mummified. And this cardiocentric or heart-centered model for consciousness was maintained for a very long time. Actually, still at the time of Aristotle, 400 years BC, there was this idea that it was the center, that the heart was the center of mental function. But this around 400 BC, there was a shift in the philosophy, as Hippocrates believed that the brain also plays a central role in mental processes, and there had to be an important balance between the mind, the body, and the environment. And again, this more holistic view of consciousness and well-being was maintained for a long time, until René Descartes in 1641 proposed this influential concept of mind-body dualism, where there is a immaterial mind that receives information from the body, but it was specifically this immaterial part that was responsible for consciousness. And this was a very influential belief, I think. And even nowadays, while probably most researchers and people believe that the brain is responsible for consciousness, rather than some immaterial spirit, I think it did the reasoning of Descartes did put forward that we put a lot of emphasis on the brain rather than viewing the whole body as important to consciousness. So this set the stage for, I think, all the research that is ongoing now, with really less focus on this holistic perspective that Hippocrates put forward. Now, how do we then actually assess patients with the disorder of consciousness? And I'm pretty sure that you're all familiar with it, but I think that Lionel Nakache has a very nice way of explaining how a neurologist, in this case an AI-generated neurologist, can assess patients in general, and that is using this 2 feet metaphor. So usually when assessing a patient, there are these 2 feet. One foot is the behaviorist foot, and this corresponds to the neurological examination of spontaneous behavior, but also reflexes and induced behavior. And this behaviorist foot can still be used in patients with a disorder of consciousness. We can use the Coma Recovery Skill Revised, the seconds, or any other validated questionnaire or assessment tool for these patients to understand the level of consciousness of the patient. And then the other foot is the psychologist foot. The psychologist foot refers to the collection of subjective reports of the patient. So really the what does it feel like questions. And we are dealing here with non-communicating patients by definition when we consider DOC patients. And so this psychologist foot is unavailable to the neurologist evaluating a patient, leaving the neurologist to have to deal or to have to stand on one leg. And in order to help the neurologist, the one-leg neurologist, many different neuroimaging-based techniques have been developed to complement the behavioral assessment or the behaviorist foot. And now this is just, I would say, I mean, it's a very nice overview, but it's a simplification, I think, of the reality, where we see that there are many different possible neuroimaging techniques, without going into too much detail right now, but there are many different or possible different techniques leading to a range of BCI or neuroimaging adjusted diagnosis. And this is, as I said before, a simplification. So the true landscape of all these diagnostic entities is even more complex. However, we can identify 3 different lines of neuroimaging-based techniques to complement diagnosis. And the first one, or the most simple one perhaps, is a resting state assessment, which is particularly useful in patients who are considered unresponsive or in the vegetative state at the bedside. And when placed in the scanner, we can evaluate spontaneous brain activity and see if these activity patterns are more indicative of true unconsciousness or seem more alike to a person being able to sustain a level of consciousness. And perhaps this might seem too far-fetched to really attribute consciousness to such resting state assessment. But on the other hand, we have to keep in mind that 80% of the brain's energy consumption is actually or happens during rest. And also these resting state recordings are very invariant across recordings and across subjects. So it's a very stable and robust measure, highlighting, I think, the usefulness of such tool. But then on the other hand, we can resort to stimulation paradigms. And here, these can be used to really probe specific questions about residual brain function. We can distinguish between passive paradigms, where a patient does not get a specific task, but the brain is merely stimulated, and we can measure the brain's response. For example, in the case of the perturbational complexity index, where we see that by delivering transcranial magnetic pulse over the cortex, we can measure the integration and the segregation over the cortex and compress this information or this signal into a single value, which is the perturbational complexity index, which holds diagnostic information. This, of course, is very useful, but perhaps not everybody would agree that that such a passive stimulation paradigm would be enough to assign consciousness to someone. And therefore, there are also active paradigms which require the willful participation of a specific individual. And some researchers believe that only this type of paradigm would be enough evidence of self-reflexiveness and hence consciousness. I think this is a discussion that is really related to your definition of consciousness, which is certainly worth having, but it goes too far, perhaps for now, to delve into the details, whether this self-reflexiveness component would be necessary for consciousness or not. But apart from this discussion, active paradigms also have the limitation that they have high levels, or they are associated with high levels of false negatives, up to more than 50%, which of course is very much, and we should definitely be mindful about that. Still, I would like to give a face to all these or to the patients that actually can benefit from these neuroimaging based assessments. There is the example of writer Jean-Dominique Bobby, who was actually a locked-in patient, which was thankfully recognized by one of his caregivers, I guess without the use of any neuroimaging in the past. But not every patient perhaps was so lucky to have such attentive caregivers, and maybe there have been numerous people like him who could have benefited from these neuroimaging techniques in the past. Then there is the case, of course, of Terry Schiavo, who also suffered a great head injury, and there were legal debates regarding her care and end of life. And actually, neuroimaging was used in court to help decision making. And more recently, we have the example of Michael Schumacher, who surely benefited from different neuroimaging tools. And nowadays he can write his autograph again on a helmet, which of course is great news. And more close to home, at least for me and the Coma Science Group, is the example of Stig Brooks, who is a famous professional cyclist who sustained a severe traumatic brain injury. And thanks to neuroimaging, it was shown that he was likely to recover again. And now he's actually working in a bike shop again. So these neuroimaging techniques and tools really have great merit and don't depend on physical function, which is, of course, very important when assessing these severely impacted individuals. And they can reduce misdiagnosis with about 40%, also in patients who do not show any signs of any behavioral signs of consciousness. And now, luckily, these techniques are also recommended to be used in different international guidelines because there are these important implications for diagnosis, treatment, and outcome. However, I think we do have to keep in mind that from perhaps the patient's family perspective, what we can give with these current neuroimaging approaches is mostly hope. So there is this nice paper of Damian Cruz where he did interviews with family members and asked their opinion and experience with these neuroimaging techniques. And family members report things like, because it was literally hope, and in the hospital they try to take this away from you, but thanks to neuroimaging, you feel hopeful again that there might be something there, because you are talking about someone that you actually love and you want the best for, of course. And here someone else reports that in the beginning, so that's the first neuroimaging assessment, and the second one, he improved, and all the positive things count. But then, hope is of course very important, but then you might also have cases where patients are not improving any further, right? That is more persistent than you would like, such a condition. And then I believe that families also wonder about questions about sentience, embodiment, affect, subjective experiences. Can he or she still feel my presence? Have ownership over his or her body, and just understand if you can do anything to make someone's life better again regarding subjective experiences. And so if we then look at neuroimaging results, it's important to keep in mind that all these neuroimaging based assessments actually depend also on the behavioral diagnosis, because the way that these techniques are validated depends on the behavioral diagnosis before being applied to other patients. And in the past, or still currently, I think behavioral assessment is mostly considered, in behavioral assessment, we mostly consider two axes, that is arousal and awareness. So this two-dimensional view of consciousness, which is of course a very limited view, and I think does not really take into account how the brain makes you think and feel. Of course, there are updates to this vision, if you will, by including, for example, motor function on a third axis, which might explain why some patients are misdiagnosed at the bedside. And also other ideas have been put forward, including that consciousness does not only rely on wakefulness and awareness, but also connectedness with the environment, the perception of stimuli, for example. And that, if someone is not connected to the environment, it doesn't mean that this person is necessarily unconsciousness, but cannot show or interact with the outside world to show consciousness. So these are, I think, limitations of neuroimaging currently. And so I think if I answer this question now, if I or we in general really study how the brain makes you think and feel, I think I have to answer that with a no. And this is probably also because right now we view consciousness and disorders of consciousness in a categorical way. So someone is conscious or not. based on this 2D view or 3D view of consciousness. But there are, of course, many more dimensions of consciousness. There are n dimensions of consciousness. We don't really know how many, but they could include also metacognition, volitional control, speech production, and basically nobody really knows how many and which dimensions of consciousness there really is. But perhaps we should try to move away from this categorical diagnosis and better focus on a multidimensional framework to capture the performance of patients across a range of cognitive and behavioral tasks, rather than this binary view. Because consciousness is a very large thing, and currently I think most assessment tools focus on sapience, or the state of awareness, while sentience, so the state of feelings related to emotions and affect, also shape our conscious experience. And this is currently, I think, ignored or not paid much attention to. So yeah, assessing emotions and subjective experience in DOC patients, it seems a bit like a Mission Impossible movie, right? Although the mission is quite clear, to reveal whether there is an experiencing mind hidden beneath the outward unresponsiveness or minimal consciousness. The assignment is relatively straightforward, but we never really receive any direct evidence of subjective feelings due to potentially sensory and physical dysfunctions, which reduces the options for assessment a lot. And also, of course, the inability to provide these subjective reports, as the neurologist has only one leg to stand on. So it seems impossible to break into the feeling of DOC patients. However, there have been these old studies, for example, that, relatively old, studies that show that this is the pain matrix, that the pain matrix is more completely activated in minimally conscious state patients and in unresponsive patients. So there seems to be the processing of emotional or stimulus with a high emotional balance. And this is also true for more friendly auditory stimulations, because we see that in response to cries or auditory stimulation with the own name, there is more widespread and high-level activation than after stimulating with noise. So it seems that these emotional stimuli are more successful in activating the brain of a patient. And the skeptic interpretation might be that, well, some increased response in these crying or own name stimulation settings might just reflect that these neural pathways are better developed than the ones for noisy stimulation. And in such interpretation, they would not be evidence for self-reflexiveness, right? That could be needed for consciousness. On the other hand, they could provide some initial evidence for retained emotional processing in DOC patients. And now there is this ongoing debate whether emotions are conscious at all, as neither bodily changes alone nor the cognitive appraisal alone are sufficient to produce an emotional feeling. But it has been suggested that the conjunction of the two is likely enough to assign consciousness to emotion, in particular if those responses are sustained. So yeah, in translating it to our DOC patients, it might mean that if we see also some bodily changes, apart from these changes at the level of the brain, this might mean that there is really some cognitive appraisal of the stimulus. So can we find any evidence of physical changes associated with these emotional stimuli? And it seems to be the case. For example, here we don't need to go into the details, but this is a study based on heart rate variability with emotional and non-emotional stimuli, and you do see that the heart rate variability is higher for the emotional stimuli. So there seems to be also evidence for these changes in the body, which I think are a small indication that there might be an emotional response. And so far we considered that our neurologist was only looking at the brain, but in reality, of course, there is a body that belongs to every brain. And now this is what AI believes to be a body. We can have some questions about that, but the brain does not function in isolation, right? And as emotions have a rich phenomenology, including that, for example, they are embodied and have a valence, so they can be positive or negative, and they have a specific intensity, a rich repertoire of assessments could be imagined to evaluate emotional processes in DOC patients by looking at brain and bodily changes. As such, more holistic approach, I think, could help to improve the diagnosis of patients, but also assess different dimensions of consciousness, and ultimately also, I think, allow for new avenues for treatment of these patients. So let's have a more detailed look at these so-called brain-body interactions. Here I put brain-body interactions in quotes because you might wonder, well, is the brain not also a part of the body, right? What is different between a brain-body interaction than an arm-body interaction, for example? But I still use the term because it's well accepted, I think, in the literature. However, I really would like to specify that I use it as an interaction between the brain and other body systems. So I think it's an important point to keep in mind. And yeah, if we look at the brain and the central nervous system and these brain-body interactions in general, without again going into a lot of details about the central nervous system and the peripheral nervous system, it's usually believed anyway that the efferent division of this central nervous system has two components. One is the somatic nervous system, which controls motor neurons and skeletal muscles. And this part of the nervous system is thought to be still under conscious control because you decide to move something or to make a movement, initiate things. On the other hand, you have the autonomic nervous system, which comprises the parasympathetic and the sympathetic nervous system, so the rest and digest and the fight or flight nervous systems, and those are usually considered to be not under voluntary control, so an unconscious part of the nervous system. However, there is more and more literature now suggesting that autonomic control is actually possible and perhaps also more common than we think. For example, we have Wim Hof, or maybe better known as the Iceman, who can voluntarily control his body temperature. Monks can do a lot of exercises with breathing, and people can voluntarily control the generation of goosebumps, which is also an autonomic function. Also, we know that autonomic functions are influenced by emotions in general. So there seem to be indications that this autonomic control can be modulated also consciously, though research is still in its infancy, and I guess a lot will be known in the future. A lot more will be known in the future about this. With that in mind, I would like to introduce some brain-body interactions that I would like to discuss a little bit today, which include heart-brain interactions, breathing-brain interactions, bodily illusions, and also gut-brain interactions. And this little blue arrow indicates what I think goes from more assessment-like tools to treatment-like tools. And I will review some of them a little bit in more detail. So heart-brain interactions have been relatively well studied in DOC patients, and it's known now that heart rate variability correlates with responsiveness in these patients, and that also minimally conscious patients have an anticipation of the heartbeat after an auditory irregularity. So there seems to be this modulation of the autonomic nervous system after detection of an auditory irregularity. Also, the heartbeat evoked responses are larger and more entropic, so more variable in minimally conscious patients, and they correlate with neuroimaging and fMRI connectivity in specific. And we have also shown that these heartbeat evoked potentials can be an indicator for covert consciousness as measured with glucose PET. So here we found that these heartbeat evoked potentials can predict better the PET-based diagnosis rather than the behavioral diagnosis, which is, of course, very promising. So we see that heartbeat or heart-brain interactions in general, they probe spontaneous but also stimulus-driven cognition. And currently the focus, I think, is mostly on the neuroscientific interpretation, but this type of investigations could be easily adapted to assess also affect. For example, to look at heartbeat evoked potentials or heart rate variability after pain or pleasurable stimulations. And then we can have a look at the brain-breath interactions or breath-brain interactions. Also, some studies have been performed in DOC patients, including one that showed that the respiration rate complexity can add explanatory value to EEG-based biomarkers of consciousness. So there seems really to be more information in these body measures rather than brain measures alone. And willful modulation of breathing patterns can also be used for communication in these brain injured patients. And they have olfactory stimuli have also been used in these breathing studies. And by combining with an olfactory stimulus, diagnostic information can be obtained. As for example, minimally conscious patients will breathe more frequently when a pleasant stimulus is presented, and they will withhold from breathing as often when smelling something bad. While in unresponsive patients or vegetative state patients, there's no such modulation. So it seems that there is really no processing of the valence of the stimulus. And this is also correlated with brain-based measures of consciousness. Now, can we measure affect? I think the previous study showed pretty well that potentially the affect could be measured, but maybe the skeptic would like to see that really there is a change in the behavior and also at the level of the brain at the same time, right? So one could imagine that a patient could be placed in the fMRI scanner and be presented with good and bad smells. And we measure then the functional brain activity of that specific patient and see whether, for example, this meta-analytical network of bad affect would appear or not when the patient is smelling something bad. And I think that could be pretty good evidence for the presence of affect in these patients. So I think that a more holistic approach in the management of these patients with a disorder of conscious might really be beneficial for the patient. Now, without adopting this or upon psychic perspective, considering that anything is conscious, right? But I do think that conscious state and conscious processing depend really on factors that are not themselves conscious but are required, like, for example, oxygen consumption for life in aerobic organisms. And in that line of thinking, I think brain-gut interactions can be important, because now I think in general it's recognized that gut health is increasingly associated with the brain's function. And this is very complicated, and I'm not going to review this all, but there are many complex interactions between the gut and the brain, and more is known about it. Also, in DOC patients, some studies have been performed, and they have shown that, for example, minimally conscious patients have a richer microbiome than unresponsive patients. And also that antibiotics actually reduce alpha power and alpha beta and beta connectivity, which are usually hallmarks of consciousness in DOC patients. So by reducing the gut microbiomes through antibiotics, we also see that the brain actually responds and reduces these type of activity that is associated with consciousness, which again is rather remarkable evidence, I think, for these body-brain interactions. And also a bad microbiome is associated with worse outcome in these patients. And now, as I said before, this holistic approach and how there can be supporting factors to consciousness, I think it's important to keep in mind the clinical management of these patients, because DOC patients, as you know, they receive mostly tube feeding, and tube feeding has a negative impact on the microbiome in other pathologies, so likely also in DOC patients. While on the other hand, homemade blend-rice foods can help to restore the microbiome. And in TBI patients, such improvements in the gut microbiome have been associated with reductions in neuroinflammation, and also are associated with better cognitive outcomes in the longer term. So I think there's definitely something there worth investigating further. And then we have also the bodily awareness or embodiment. So yeah, this bodily awareness is, of course, a broad topic which includes interoception, body ownership, agency, proprioception, and embodiment. And I think these type of investigations could provide insights into the affective dimensions of behavior and the mind and brain, and might potentially be a new indicator of consciousness as well, or multiple new indicators of consciousness, including, for example, multisensory integration in a rubber hand illusion paradigm, for example. Maybe for the sake of time, I will skip over that, because you might think, well, blah, blah, blah. This is a lot, but what does it really mean? I should have some strong scientific proof for this. And I'm honest that I don't have that at this point, but we can take a look at other measures, how other measures have been established and are now well accepted. So let's take the perturbational complexity index as example, which I think might be really the most accepted measure for consciousness in DOC patients specifically. And well, I've briefly introduced it before, and I also think that you are probably all familiar with it, but the PCI gives this cutoff for unconsciousness versus consciousness. And before it was applied to DOC patients, it was also validated in other states of unconsciousness, including sleep, but also different anesthetics in healthy volunteers. And following that line of reasoning, we might be able to validate body-based measures for consciousness as well in independent samples, including healthy volunteers and communicating subjects specifically. And building on that, we know, for example, that interoceptive dysfunction can lead to a wide range of physical and psychological symptoms and disorders in really a wide range of populations. Also, keeping it more simple, if we have our neurologist here who's not happy with her wrinkles and she would decide to take some Botox in her laughing wrinkles under her eyes, she might start feeling more depressed because she cannot laugh so well anymore and her body is being fooled as if she's not happy. While if we would inject Botox in her frowning wrinkles, her body will be fooled once again, but she will start to feel happier, or is more likely to feel happy because she cannot frown and overthink as much anymore, or at least not have the bodily movements associated with that. And there are more successful examples, I think, where we use this bodily information to assess subjectivity in the general population or patients with nightmare disorder, for example. Here we see that we have a heartbeat evoked potential with a higher amplitude, specifically around 400 milliseconds after the R peak, when suffering from a nightmare. And now this increased heartbeat evoked potential has been accepted as proof for people experiencing a nightmare while dreaming. And also more straightforward, perhaps, we do look at bodily signs of potential awareness during surgery. And everybody, I think, kind of accepts that tachycardia, hypertension, sweating, and so on might be signs of intraoperative awareness, and the medications are adjusted in the operating theater if those signs are present. And also psychedelic experiences show evidence of these interactions between bodily function and subjective experience. Because here we see that heart rate entropy correlates with brain entropy, but also with the subjective experience that participants report. And they actually correlate stronger, I believe, than the than the brain-based measures specifically. And yeah, I would also like to take things even a step back, perhaps, really to biology, because else you might believe that this discussion about sentience and consciousness is mostly a philosophical one, right? Or perhaps at best also relevant to the clinical management of DOC patients. But if we look at the generation of action potentials, for example, I don't think we can really go back in biology much more than that, at least not for the humans. But if we look at the generation of an action potential, you see that the resting membrane potential is around, or can be around, minus 70 microvolt. And an action potential is generated when this resting membrane potential is pushed towards minus 55 microvolt. And we see that the base rhythm of the cortex when measuring or when doing electrophysiology depends really on this resting membrane potential. So if this potential is around 70 microvolts, so rather negative, you see that the brain will start to oscillate in the delta frequency, so around 1 hertz. While if it's slightly less negative, so minus 60 microvolt, then you see theta rhythms to be more dominant. And especially in DOC patients, theta is usually a good sign. So we might wonder, how can we then push, or what decides this resting membrane potential, right? How can we have it closer to minus 60 than minus 70? And it seems that afferent sensory input might play an important role here. So this can be any sensory stimulation: hearing, smelling, seeing something, touching, pain, anything really. Just any sensory input might help this to drive this resting membrane potential to a less negative value, so closer to the generation of action potentials. And again, while the input itself might not reach consciousness initially, it could drive the network to support consciousness, which is also in line with the mesocircuit hypothesis. And I think some preliminary proof or linked proof is present in patients in the acute phase after brain injury, where somatosensory evoked potentials like the N20 are predictive for outcome and are a positive predictor for outcome. And also in the longer term, there is some meta-analytical evidence for the importance of sensory stimulation. And I was rather surprised when I saw this meta-analysis, because at first I didn't really, well, it was not fitting with my beliefs back then, at least, that sensory, but they found, these authors found with their meta-analysis, that sensory stimulation is actually the most successful type of treatment for patients with a disorder of consciousness. And it's more successful, it seems, than non-invasive brain stimulations like TDCS, vagus nerve stimulation, or RTMS, which of course is great for clinical perspectives because it's relatively easy to perform, at least compared to non-invasive brain stimulation. And yeah, you can wonder, but why sensory stimulation? Because actually non-invasive brain stimulation techniques should also decrease the resting membrane potential. So why then does it not work equally well? And I don't really have a full answer to that, but perhaps it's because sensory stimulation actually passes through the thalamus and can reach the cortex in a better way using these well-established pathways rather than the top-down modulation usually provided with non-invasive brain stimulation. But perhaps a combination of this more bottom-up sensory stimulation and top-down non-invasive brain stimulation would be even better to treat patients and improve consciousness. So yeah, to conclude, is there any strong scientific proof that allows to assess emotions directly in DOC patients? Well, not yet, unfortunately, but I would like to invite everybody to think slightly different and consider more holistic approaches when assessing patients and also when designing new experiments that include more parts of the body. Because I do think that there is this important clinical impact for diagnosis, one, but also to assess these other dimensions of consciousness associated with feelings, which are, I believe, very important to the loved ones of patients and can also help in ethical debates regarding end of treatment, end of life. And of course, I also think that these brain-body interactions can have an important impact on the development or refinement of treatment procedures, and they might facilitate recovery in DOC as well. So, well, I'm wondering, can we make the next difference in the management of DOC by assessing correlates of subjective experience from bodily function? And I am tempted to say yes. We might be able in the future to do that, so that our one-leg neurologist will have back her second foot and becomes a normal neurologist again. So thank you all for your attention. I would also like to thank, of course, the whole Coma Science Group, Daniela Marinazzo, and all the funding agencies who fund the research, my research, and all the research that I've been talking about. And I'm happy to take any of your questions. Thank you.
Thank you so much, Jitka. It was a wonderful presentation, very insightful, very clear and didactic. So yeah, I think that we know that the field have moved forward dramatically the past decades, but you just showed us that there's still a lot that we can do to refine the diagnosis and the management of patients with disorder of consciousness. Thank you so much. I will now take questions. So I don't know if someone in the chat or in the audience have any questions or remarks to share with Yitka. So we have Narida Sanders who said, thank you so much for the wonderful insight. While maybe others are thinking about questions or writing questions, I have a few questions I wanted to ask, maybe just for the recent meta-analysis. Obviously, that's also the results are also are intriguing me. So the sensory stimulation, I have not read the paper in detail, but do you know if it was repeated stimulation? Because of course that might have influenced a lot. And it was only based on 2 studies. So I don't, was just wondering, was it more? Or maybe I misread. So maybe if you can clarify
Yeah.
the point, otherwise I will read the paper.
No, sorry. Am I still sharing? Yeah, I was trying to go to the slide. No, it's based on multiple studies. I'm not sure they actually took into account if, yeah, here you see many different studies. So yeah, there are pre-post, pilots, and randomized trials. If they were repeated, I don't know.
Because the pre-post, I guess it's not with a control condition. So there is no, it's
No,
the open label studies, which also might influence the results. But
yeah, true. But they are
I,
present for both anyway, for
okay,
both type.
I will read that.
Yeah.
Thanks. And maybe one thing that is a bit, I mean, a bit not exactly what you presented, but it's about more the multiplicity of all the testings that we can do. We don't do them enough, but we could do a lot of different testings with the patients, different techniques, approaches. And there's this recent paper by Ho and Yon and Nakash that was published last year in Nature Medicine, showing that the more you increase the modalities, the more the diagnosis is refined. So basically, that's the more you detect minimally conscious state, right? So, and I know we briefly discussed that, but here they take into account, and this is also the approach that we take here at the Common Sense Group Liège, is that we kind of think that it's always we take the approach of the false negative, like if you see one assessment that is positive, then you will consider the patients as minimally conscious, which might not be the case. So I just wanted to have your thought about that, and yeah, and if you think that there is one modality that may be more sensitive or accurate than the others.
Right. Yeah, so this is something that I've been thinking about a bit lately as well, that by just applying more techniques and also performing more analysis of the same data, right? Even just looking at fMRI or any neuroimaging, basically, so many different metrics can be developed, and they might not go in line with each other. And I was wondering, well, if we just continue with the development of new measures, will there be any true unresponsive patient left, right? So I don't know. I did discuss this briefly also with Lionel Nakash, and I mean, they would only attribute consciousness if they were sure about the specific modality. So it was not like they had to be extremely sure in order to suggest that the patient was minimally conscious or covertly aware, if I understand well. I think we could do perhaps better by also acknowledging that all those techniques are not completely independent from each other, right? I mean, we are still looking at the same brain, and this is not, I think, taken into account a lot, and perhaps we should develop some techniques to that quantifies really the likelihood of someone being minimally conscious with a given set of neuroimaging parameters, which might help to refine a bit better the diagnosis rather than taking this taking the approach that if any measure suggests consciousness, then the patient is minimally conscious. But I don't really have the answer right now. Of course, also including more measures to assess these more bodily related signs of consciousness might complicate things further. At the same time, I think they really allow to measure other aspects of consciousness, or maybe not even consciousness per se, but just yeah, feelings and yeah, other dimensions. So yeah, it might complicate things further, but might also help in a way. Yeah, it's not a full answer to your question.
Yeah, no, thank you very much. And yeah, I fully agree. And also maybe in that paper, they mainly rely on task-based paradigms, if I'm not wrong, which really give more information about the actual residual neuronal processes of patients. While we at the Common Sense Group, we do mainly resting state, which is a bit less informative in terms of the really the residual um, consciousness content.
Yeah, that's true.
All right, then we have a few questions. So Priscilla is asking, what kind of sensory stimulation was it for the meta-analysis, I presume?
Yeah, I think so too. For sure, it was a music stimulation, and I think most of it was music, but also tilt table was included, for example, and yeah, any type of sensory stimulation really. So it was not specific. I don't think they had any exclusion criteria on that regard.
Right. And then Beidang is also thanking you, wonderful presentation. Thank you for your sharing the current evidence and your perspective. Any other questions for Litka? All right, then we are perfectly on time. Thank you so much again, Yitka, for the wonderful presentation, and thank you everyone for joining. Again, the recording will be sent to you, I think, yeah, tomorrow by the end of the week. Thank you very
Thanks.
much.
Thank you.
Bye, everyone.
Bye bye.
Thank
Thank
you.
you.